applications on the back. Do you want to try it? And then just have your badge. Yeah, just take your badge. Oh, thank you very much. And one last thing, when we do finish, it would be really nice to get a group shot of all of you together. So we'll do that before we do questions. I like the orange.
Yes. I was thinking about it actually.
Excellent. I like it. Orange.
Orange is the new black.
It's just that she took her coat off. I noticed it straight away. Okay, are we good to go? Let's look in. Are we good to go, Eric? Yeah. Sorry. I'll count down. Yeah, we have an online audience, so we just to make sure they're all plugged in. Okay. Yep. Good morning and good afternoon to you all, and welcome to this official hybrid press conference of the 27th World Cancer Congress. I'm Cary Adams, the CEO of the Union for International Cancer Control, otherwise known as UICC, based here in Geneva, and we are the conveners of the Congress. A warm welcome to you, media representatives who are here today, and to those of you who are watching online. The UICC is the largest international cancer NGO of its kind, with some 1,200 members around the world, and our mission is to both unite and support the cancer community in its efforts to reduce the cancer burden, promote greater equity, and ensure that cancer control remains a priority on the global health and development agenda. The World Cancer Congress itself also dates back to 1933 and was first held in Madrid in Spain that year. It's since traveled around the world. It's been to cities as far as Moscow, Sao Paulo, New Delhi, Shenzhen, Budapest, Washington, Paris, Melbourne, and Kuala Lumpur. It's wonderful to be back here in person again. Kuala Lumpur was our last Congress in 2018. UICC also looks to partners for the World Cancer Congress, and I'd like to both thank and welcome our co-hosts, the Swedish Cancer Society, the Dutch Cancer Society, the Institut National de Cancer, Gavi, the Vaccine Alliance, Geneva University Hospitals, AJUG, and thank you very much for being here today, the International Society of Pediatric Oncology, the Nordic Cancer Union, the Norwegian Cancer Society, and Unitaid. We're also privileged to work with the World Health Organization, the International Agency for Research on Cancer, and the International Atomic Energy Agency. The World Cancer Congress is in every respect the coming together of the global health community. Now, before I introduce my esteemed colleagues sitting here with me today, let me set out some context briefly. In 2020, there will be nearly 20 million new cases of cancer and 10 million related deaths. Breast cancer has now surpassed lung cancer as the most commonly diagnosed cancer. Sadly, some of the common cancers that we know how to treat successfully when they're detected early, breast, cervical, colorectal, and prostate, are causing high mortality in low and middle income countries because of a lack of screening, early presentation, and treatments, a lack of treatment services. We see this inequity in childhood cancer, 80% survival rate in high-income countries and as low as 20% in low and middle-income countries. Of course, the pandemic has laid bare just how vulnerable to infection, serious illness and death from the novel coronavirus people living with cancer were and continue to be. You'll have heard and seen already some sessions around this at the Congress this morning, and there will be more presented this afternoon on the link between cancer and COVID-19 deaths. There's an abstract presentation at 1:40 for those of you interested. On a broader level, the pandemic has demonstrated the folly of not investing in public health, and more specifically, non-communicable diseases. I think the recent report from WHO on NCDs has certainly drawn a line in the sand. NCDs account for 3/4 of all deaths globally and are expected to cause more disease and death than infectious diseases in lower middle-income countries in the future. Families in Kenya and India are just as concerned today about diabetes and cancer as they are about HIV and tuberculosis. Low and middle income countries are very well represented at the Congress, and I know there will be rich discussion around the changing disease landscape in those countries and regions. We're expecting some of the science to be presented on the issue to make news, in particular a study that estimates the cancer burden in South Africa by 2030. If the focus on NCDs has sharpened somewhat over the past few years, so has the discussion around disease prevention and investing in health systems. I think too that the pandemic has raised health literacy in the broader community everywhere. I also believe, despite the disinformation out there, that most people can appreciate the benefits of modern medicine and science now that they've been seen. Our vaccines have in many parts of the world enabled us to live through, albeit imperfectly, the COVID-19 pandemic. The pandemic, of course, has also provided some silver linings in terms of partnerships that have been formed, cross-border collaboration in research, telehealth, mobile screening, and virtual fundraising, which is so important to the UICC community. The Congress will look at all of that. It'll feature sessions that will talk to prevention, screening, early detection, review cancer research and progress, debate healthcare systems and policies, consider the latest developments in cancer treatment and palliative care, and give voice to people living with cancer. With that, before introducing our first speaker, let me run through some housekeeping. The press conference is being broadcast live and on the conference platform and will be recorded and made available to participants as well as on the UICC YouTube page shortly after it's ended. Today, we'll be hearing brief remarks from all speakers. Then I will open up for questions from our media representatives attending today, both in this room and outside online. Now, to those of you physically in the room, we will pass around a microphone. Please indicate your media outlet, your name, and who you wish to direct your question to. We will then direct the question to the nominated panelist and we'll have an answer, and then we'll move on. To those of you who are watching online, please type in your question in the chat box and also indicate your name, who your affiliation is with, and who you would like to direct your question to. Please keep your questions brief, and we will try to keep our answers brief as well. Okay, let's begin. Our first speaker is Bente Mikkelsen. She's the director of the Non-Communicable Diseases at the World Health Organization. Bente will expand on the global situation for cancer, give you more information than I've given you so far, and how governments can reduce the burden of cancer in their countries. Over to you, Bente.
Thank you very much, Cary. And I would like to start and really thank you and UICC and all the partners for organizing this World Cancer Congress. And as you said, it's really been many years, 4 years since we did this the last time. And coming back to the figures, that means that we have lost 30 million people to cancer in the same period of time. And I think this is what we need to think about. And this is my motivation every day, to think about the people suffering, living with, affected by, as we have seen already during this conference. I was very happy that we had a person with lived experience as the onset of the Congress. And it's not to have any iconizing, it's really because we want to co-create with those who are living with cancer. So it's been really a pleasure to support the Congress from our end, together with our sister UN agencies. So the burden of cancer did not pause, as we know, during COVID-19, and you mentioned it already. We had huge disruptions. So one of the first things we did in 2020 was to do a rapid assessment. And we did this actually because we had healthcare workers and families and people affected by cancer and other NCDs telling us something very bad is happening. And we saw disruptions of 50 to 60%. And this is happening because the health system is actually too weak. And this is not a new thing, it's just a disclosure. So there has been reduced participation, both for health-seeking behavior, for early diagnosis, but also treatment and follow-up. And we have a big backlog, and we have to be very clear. There is no preparedness without including cancer into universal health coverage. We will not be able to manage a new pandemic, or for that sake, a humanitarian crisis, unless we build the health system stronger. So as we have heard during the Congress, we have to make up for this loss of ground. There is a strong commitment from all stakeholders to elevate cancer as a political priority. At WHO, we are at the moment supporting more than 70 governments to implement our 3 major cancer initiatives on cervical cancer, on childhood cancer, and on breast cancer. And we don't do this alone. We do this with partners, and we need more partners to help us to implement and also to get the normative work right, so it's really translated into action. We have expanded our networks to support implementation with more than 200 partners so far, and we hope for more. And we will soon also introduce an implementing partner platform, so you can all see and learn more on how this is happening. We have tools that are supporting governments to make strategic investment in cancer and also to mobilize development partners to activate their capital. These tools are currently being used to support governments in every WHO region, as I think we heard from the RD of EMRO today. Currently, 70% of or more of people diagnosed with cancer in low and middle income countries suffer financial hardship. And what does it mean? It actually means that they pay out of their own pocket for things that should be covered by the governments. And this is very often a choice between food care of the family or actual treatment and diagnosis for the people that is involved. Finally, yesterday, we are launching a campaign to amplify the voices of people affected by cancer. This is to better define the impact of cancer on social, emotional, and financial well-being. So I take the opportunity to invite anyone affected by cancer as a survivor, as a caregiver, or any other related to respond to the surveys that we released yesterday. I invite you to share your story and shape the future. So thank you again, UICC. You have always been there. Without you, we would not be at the stage we are today, but we need more collaboration, and thank you again.
Thank you, Bente, and I should say thank you to WHO for the great work that you do in NCDs more broadly, but also in cancer. Bente said it affects everyone. I occasionally do this, but perhaps I could ask in this room and online, if any of you have had cancer or you know someone close to you, a friend or family member who's had cancer, perhaps you could put your hand up. So my next line says cancer affects nearly everyone, and you've just proved that. We're all affected by cancer, and it's my great honor to pass on to the baton to Alejandra de Cima Aldrete. Alejandra is a cancer survivor and the founder and president of Fundación. Is that correct? Fundación. My Spanish is getting better. Fundación CIMA, a survivor and patient group based in Mexico, and I believe celebrating its 20th anniversary this year too. And UICC is celebrating its 90th next year. So over to you.
Wonderful. Thank you, Cary. My name is Alejandra de Cima, and I am the founder and president of Fundación CIMA, a nonprofit organization working since 20 years in Mexico in the fight against breast cancer. As Cary mentioned, I'm also a breast cancer survivor myself, and I would say the living proof of what early detection can do. 22 years after my diagnosis. Sadly, in a country like Mexico, this is one of the very few cases. After rather mild course of treatment to cure my cancer, but still pretty scary, I felt the need to do something in return of that second chance I was being given to life. And I wouldn't have forgiven myself if I hadn't done something in return and to my people and to my country. And this is how Fundación CIMA was created in 2001. Around 70% of all breast cancer diagnosis in my country happens when the cancer has already metastasized. And this is a very, very terrific and I would say unnecessary statistic that needs to be changed. I cannot straighten the public health system, and I can't provide medicine to all those women that suffer cancer. And I can't provide the medicine that the local health providers should have given them. But I will definitely focus on the things that I can change. And I will work on publishing educational campaigns, and I will create innovative ways for getting the community's attention. And I will definitely continue offering support to people that struggle with cancer. And I will provide them with the post-surgery supplies that will bring back their self-esteem and the strength that only health can give them. But I will make sure not to do that alone. I will make sure to collaborate with key partners, local NGOs, definitely international organizations like the UICC, legislators, government. And I will be so consistent and so incredibly loud that my voice will have to be heard. Every day I hear horrible stories about massive shortages of medicine, about women that have to wait months before they get seen by a specialist, of women that die because they didn't have the money to continue their treatment. So my commitment today with my people in my country is to improve the lives of people living with cancer through changes in the legislation. The most meaningful, efficient, and with the utmost reach being the general cancer law for Mexico that is currently being drawn up by 13 NGOs, Fundación CIMA included. This will serve as the very, very needed legal instrument that will allow us citizens to demand the public policies that ensure the quality and timely medical care for cancer patients. It will force also the government to comply to its sections, which include, amongst others, the National Cancer Plan and the National Cancer Registry. Thank you very much.
Thank you very much, Alejandra. Of course, the impact of cancer goes far wider than just being a health issue. It's far wide-ranging impacts economically, financially, and of course, socially. Our next speaker is Valerie McCormack, who is the Deputy Branch Head of Environment and Lifestyle Epidemiology at the International Agency for Research on Cancer, IARC, based in Lyon, and another partner to the UICC. Valerie will talk to some sobering data that they've collected on maternal orphans, which have been orphaned through cancer, which I also understand is the first time that this global estimate has been presented. So Valerie, thank you very much for being here today. I hand it over to you.
Thank you, Cary, and thank you to UICC and the World Cancer Congress for highlighting this abstract, which we presented later this morning. So to date, the intergenerational effect of cancer deaths hasn't really been given much attention. And so I'll talk today about maternal orphans due to cancer. So that's a child who's lost their mother due to cancer. The impetus for the global estimates is a prior study in Africa on breast cancer. At the International Agency for Research on Cancer, we followed 2,000 women who were newly diagnosed with breast cancer across 5 sub-Saharan African countries. And sadly, this is just over the last 5 years, and sadly, more than half of those women have already passed away. And upon contact with their family to find out that they had passed away, we asked, well, what's the impact on the family? And we were struck by how often the husband or the next of kin expressed concerns over the children. And we were able in that study to estimate, well, how many children were left behind when their mother passed away? So children still under 18. And in that study, overall, so for a breast cancer death at any age, for every 100 women who died, more than 100 children became a maternal orphan. Of course, if you die of cancer at an older age, your children are usually already adults. So the highest ratio of maternal orphans to cancer deaths occurs usually when the woman dies around her 50s or 40s. So we were quite shocked by those statistics and realized actually the issue of maternal orphans due to cancer, orphans due to cancer at all, had never been highlighted, unlike for HIV and other conditions. So in the abstract that's presented today, we provide the global estimates. So estimates of maternal orphans due to cancer across 185 countries by country and across all cancer deaths. And in a nutshell, the sobering figure is that for the 4.4 million women who died from breast cancer in 2020, 1 million children became maternal orphans in that year alone. And in 2021, another 1 million children became maternal orphans. And Not surprisingly, 45% of those 1 million maternal orphans are due to breast and cervical cancer deaths. So by no coincidence, these are the two cancers that WHO has cancer initiatives, and they're two cancers where we should be able to reduce that mortality burden through HPV vaccination, screening, early detection, and quality treatment, and avoid then the impact on the next generation. Why is this important? Well, we know from studies of orphans in general, which haven't had a cancer focus, but orphans in general, they, in some settings, they have lower educational levels, they have higher mortality than their peers. And so it's not only the women who die, we need to prevent their deaths, but it's also that next generation. So for the 4 million women who die, another 1 million children are affected and become maternal orphans. So I'd like to thank you for highlighting this. We will, just on the last note, we hope to estimate paternal orphans, but our focus on maternal orphans came because at ages 35 to 50, when cancer deaths often generate orphans, in almost every region globally, women are disproportionately affected by cancer deaths. At older ages, it flips and men are affected, but we will be addressing that later. Thank you.
Thank you very much, Valerie. As I touched on earlier, low and middle income countries carry the highest burden of cancer. In fact, it's predicted that mortality due to non-communicable diseases, including cancer, will surpass communicable diseases in places like sub-Saharan Africa by 2030. Now, to hear more about the challenges of the African continent, joining us today is Miriam Mutebi. Miriam is a UIC board member and consultant breast surgical oncologist at the Aga Khan University Hospital in Kenya. She is co-author of the Lancet Commission report on the growing cancer crisis in sub-Saharan Africa. Miriam, the floor is yours.
Thank you, Cary. And I think really just reflecting on the numbers that you've mentioned, we are really in the cusp of a syndemic, which is basically a constellation of epidemics. We're dealing with the communicable diseases aspect. We're now starting to see an increase in the non-communicable diseases, and we are definitely having that translate. Unfortunately, despite all the advances we've seen on the continent, whether it's in terms of an increase in cancer control programs or an increase in cancer treatment services, the reality is, as Valerie said, the majority of our patients are still getting diagnosed with advanced disease and frequently not completing their care. And if we do a deeper dive into the reasons behind that, we see reasons that Bente outlined around financial toxicity, the fact that patients are having to pay out of pocket. Keep in mind that most, especially when we look at women's cancers, women are I would say predominantly engaged in non-informal employment, and so more likely to experience financial toxicity than everyone else. And then looking at the systems challenges that exist, where we know in sub-Saharan Africa, women patients will see on average 4 to 6 healthcare providers before definitive diagnosis of their cancer is made, really just underscoring the need for increasing awareness, not just in the community, but also amongst healthcare workers. And again, looking at the social cultural impact of and social cultural barriers that Valerie eloquently outlined, we really see in many parts of sub-Saharan Africa, and I think that this is true for quite a number of regions in the world as well, women are not the primary determinants of their health-seeking behavior, and as such, either require permission or sometimes financial support largely in order for them to access care, all of which translates into delays in diagnosis. And again, we look at the pervasive social cultural barriers that exist, stigma, cancer fatalism, or collectivism, where we say in Africa, our strength is our community, but if that translates, that can sometimes be a double-edged sword where decisions are being made for the patient without necessarily them having agency. So it's really looking at how do we shift narratives around this. And a couple of pointers exist from the Lancet Commission, and we say there is a need for robust data. We do need to document, we do need to know what's happening to our patients, patients, how are they responding to treatment? If they're falling out of treatment, what are the reasons behind this? We do need to invest in innovations, but it's not just innovations for innovation's sake. We're saying telemedicine has the potential to bridge some of these gaps, but how do we effectively integrate them into the existing frameworks? It's not just technology for technology's sake. How practical and how are they adding value? And I think there's also opportunities, as we said, for collaboration, really looking along the pricing aspects of things, and also really around shared decision-making, whether it's in treatment aspects or advocacy. Thank you.
Thank you very much, Miriam. We're seeing incredible advances in screening, diagnostics, and treatment on the horizon. And this will be a particular focus of the plenary session tomorrow when we're talking about what are the breakthroughs that we can anticipate in the next 10 to 15 years. Our final speaker today will talk us through some of those innovations he and his staff are engaged in Geneva, Switzerland. Olivier Mikkelsen is the newly announced chairman of the Department of Oncology at the Geneva University Hospital and a partner to the World Cancer Congress. So please go ahead, Olivier.
Thank you very much. It's really a great pleasure and an honor to be here. We value extremely highly this relationship with UICC, and although I'm very new in office, I really look forward to many years of tight collaborations. So clearly, the cancer research is really active. We have had very important breakthroughs over the last years. One of them is clearly immunotherapy. I am a physician treating melanoma patients, and I started with chemotherapy some years ago with absolutely little effect, if any. Now with chemotherapy, my goal when I enter the room with a patient is to get a cure, even if the patient is highly metastatic. We don't succeed all the time, but now we have the latest data showing that we have over 50% of the patients that are alive and well at 6+5 years without treatment for most of them. So I think a decent fraction of these patients will be cured. So clearly this is an incredible step forward. Immunotherapies do not work as well for other type of cancer, and for some cancers, they do not work at all. However, it's clear that these are here to stay, and this is very an important question for the future. How broadly can we disseminate these? And it turns out that they might not be unsuitable for these, as sometimes polychemotherapy can be very difficult to apply in some countries because of risk of infections, and the immunotherapies might not suffer from this. So as we're moving towards cheaper drugs, more generic formulation, maybe this could really be a path to follow in the years to come. We also have revolution in the cell-based therapies, where we can now use engineered T cells from the patient to really gain incredible control of some of the hematological malignancies. This is also an area of great interest with cure rates that are really interesting. Very expensive at the moment, but again, the technology is evolving towards off-the-shelf CAR T cells that could be used without the need of these extremely heavy logistics to get the cells from the patient and transform them. Clearly also something to look at for wider dissemination in years to come. And all of these aspects really call for better patient selection. How do we select the patient who are going to derive benefit from an immunotherapy, and those who will just lose time in oncological term in these treatments? And everywhere around the world, and in Geneva, we are building precision oncology programs. We have announced on Monday the creation of a new clinical service of precision oncology at HUG, with the aim to really find all the biomarkers that allow us to pinpoint to those patients that are in need for immunotherapy, and those where the benefit will not be the one we are trying to get. And it's very important because these selection mechanism could be deployed in many countries. So I think this type of research hopefully could also be useful at some point to really select the patient that really are in their need for this or the other type of immunotherapy. So clearly the research is going on, and we have an absolute need to find solutions so that this can be deployed broadly in the years to come, and that's something that is very dear to our heads. So thank you very much.
Thank you very much, Olivier. We're now going to move on to questions and answers. I think we've got about 10 minutes left, so let's see how many we can get in. To those of you who are in the room, again, if you could indicate name, media outlet, and who you'd like to direct your question to, that would be great. And those of you who are online, if you could complete the chat box with the same information, then someone will be waving me at the back of the room and will hopefully tell me if there's any questions that have come through on that. So please keep your questions brief. I now open it to the floor. Could you please raise your hand if you have any questions? The microphone's coming round.
Hi, thanks very much everyone for those presentations. My name's Jessica Abrahams. I work for DevEx. This question, I suppose, is mostly for you, Cary, because it's about the Congress itself. There's been a lot of discussion lately about the accessibility of global health conferences held in Europe and North America. I'm sure all of you heard about the issues that African delegates had accessing the AIDS conference in Canada recently, and I think there were some issues at the World Health Summit in Berlin last week as well. So I just wanted to know if you're aware of any issues with delegates reaching this conference here, and also if any of the panelists have any thoughts on that issue more broadly. Thank you.
Wherever we've taken the Congress, we've had issues with some people getting visas. Unfortunately, that's something which is a political decision down to the local government. We work very closely with delegates to make sure they have all the right paperwork, the invite and everything else. My team are on the phone the last minute to try and get everyone to the conference who wishes to come to the conference. Unfortunately, that's not been the case. We have had some examples of individuals who couldn't get into Switzerland. Having said that, what we have done at this conference, which is for the first time, is that we have an online solution. So we have, I believe, over 400, I'm looking at my team, over 400 individuals who are able to log on to the platform, see the complete online platform that was pre-recorded, and see all of the recordings of every session that takes place here. And that is available to them for the 3 months up to the end of the year for them to have access. And that's important for UICC because, as I said earlier, our purpose is about addressing inequity around the world. This is the first time we've done it, and we're really proud that we've got so many individuals from predominantly low middle income countries who are dialing in today and getting the value of this Congress as displayed by the individuals we're seeing here today. Are there any other questions? The lady here.
Good morning, Irma Dalia from Italy, La Repubblica. My question is maybe for every one of you. You can choose. All the world is facing a deep crisis after the pandemic. We are now facing the energetic crisis following the Ukraine war. And are you worried about the risk that in the world, people will have more attention paid to lifestyles, health and prevention following as a consequence of these other economic crises?
Bente, I don't know why, but you leap to mind as someone who could probably start the answer to that one. Would you like to start?
Thank you very much for the question. And I think you're setting out the very dark picture that we see. So what we do at WHO with partners is that we work on frameworks for preparedness. So we really utilize the moment that was coming through the COVID, helping governments to also include measures. That said, we know that we have had industry pushing alcohol and tobacco, and we also know that physical inactivity was increasing because of many things. Also, the pure fact that there were no funds for actually getting to a transportation. And the unhealthy diet has also been seen as increasing. So I think my answer to you is that we need to just work harder. We know what to do, and we need to help the governments, and we need to push really a strong voice to also focus on the non-communicable and the communicable diseases, because in every crisis, there is a tendency to go back to the traditional way of tackling humanitarian crisis and also environmental crisis. So I think it's a strong message to all of us to voice the need, and there is a risk. I think we just have to admit that.
Perhaps I could just add one other point. I mean, one of the concerns that we have is in this financial economic crisis that governments that traditionally have made overseas development assistance available to low and middle income countries to address health issues are probably going to be cutting back on that assistance. And that would be very worrying at a time, as we've described earlier, where the burden of cancer is most prevalent is in low and middle income countries. So I would just add that as a potential risk as well.
I forgot one very important point, and I was looking at our colleague from HUG. So of course, as I mentioned also in the opening yesterday, we also need to work harder on the digital solutions, self-care. I mean, there is also an opening for innovations. So I think we need to call on that. And it was a pleasure to actually participate with the CCAN earlier this week, who had invited young female leaders and really have a rapid training and utilization of their engagement. So that's one innovation also. So I think we need to look at that space and call on partners from all sectors to support a better way of do service delivery and also to advocate for non-risk behaviors.
There's one more question, I think.
Hello, good morning. I'm Lucia from Spain, from El País, and my question is for Valerie McCormack about the study. I wanted to ask you, how did you measure these 1 million maternal orphans? How did you measure? And also, where are they, and what are the types of cancer that killed their mothers? Thank you very much.
Could you pass the microphone on? Thank you.
Thanks for the question. So the methodology is a modeling-based assessment where we take the GloboCan data from the International Agency for Research in Cancer, which provides estimates of the number of women who die of cancer, and the most recent estimates are for 2020. They're provided by country and by cancer type. So we've combined those, looking at the age of death that the mother died with the national level fertility of that woman throughout her prior reproductive life. And that data comes from the United Nations World Population Prospects. We obviously adjust for the fact that some children have already passed away before the mother dies, the background mortality. And we also take into account that the reproductive history itself can raise or lower your risk of cancer and thus of death. So it's a little bit complex. You don't want the formula, but they're the data sources. I mean, when we compare the model-based data with the previous study of breast cancer in Africa, the estimates are very plausible. In terms of the types of cancer causing most of the maternal orphans, it's a complex picture and it varies across the world, and these the data by country in a lot of detail will be published before the end of the year, and we will upload all of the data at the country level to the Global Cancer Observatory. So it does vary between countries, but breast always appears in every country, and globally it's breast and cervix. Then what are the regions most affected and the countries most affected? It's countries where the risk of a mother dying of cancer at a young age, so the risk of a female dying from cancer below age 50, they're the countries where the child has the highest risk. And there's different ways to measure it, and all of these will come out in the paper. In terms of how many children left behind per mother who dies of cancer, which is a slightly different metric, that essentially reflects her past fertility. So countries with very high fertility rates come up high there. Okay.
Thank you for that. I understand we've got an online question.
Yes, it's from Jackie Thornton at The Lancet. It's also to Valerie. did you see a gender difference on effect on maternal orphans on the children?
Yeah, we don't have the gender of the children, so that's not, it's been something that we've looked at. Yes.
Okay. Okay.
And also,
Another question from online.
yes, from Cary Cullinan, Health Policy Watch. Has UICC and or WHO engaged with any drug companies about treatment prices, especially for immunotherapy, gene therapy, as these are out of reach for most LMICs?
I can answer from a UIC perspective. No, we haven't. What we have done is engaged with the pharma, generic and biosimilar companies that produce medicines which could be very effective in low middle income countries, to see whether or not we can find ways to get their medicines into those countries, either by increasing donations, by tier pricing, or using a voluntary license mechanism. And those discussions are ongoing at the moment through a new coalition that we formed called the Atom Coalition. But I know WHO is passionate about the availability of medicines as well.
Thank you very much for the question, important question. So what we do at WHO, we have every 6 months private sector dialogues where we have defined asks for most of the diseases, and we call for commitments to be able to increase the access to medicines and devices. So on cancer, our focus is now, of course, the medicines that are already on the essential medicine list, but we don't shy away for also innovative new drugs and devices. So I think what we have achieved during the last couple of years is a very structured way to discuss this in a safe way as well, trying to really combine the due diligence that needs to be there with the need of the patients. Thank you.
We have another question. Mark Lodge. Hi, Mark.
Thank you. Mark Lodge from Cancer Control 2022. Climate change and cancer, seems to be a little bit of a gap when people are talking about cancer and not talking about climate change, and that's the background that we're all having to live with. Can the panel make a comment about how the cancer community should be more engaged with climate control?
Yeah. Shall I start off with? I agree with you, Mark. I think it's something that the cancer community should be more involved with. And I would extend that to say the non-communicable disease community should be more engaged with, because the issue of air pollution and NCDs and cancer is a growing problem, particularly with an urbanizing population around the world, where I think the anticipated percentage of individuals living in cities by 2050 is well north of 60%, I think it is. So it is something in the longer term I think we need to be concerned about. And I'm not too sure whether they have any sessions this time around at the Congress, but I think at the next Congress we need to make sure that we do have sessions on that, so we can educate the cancer community on the challenges that we face.
So thank you for the question. And I think this is one of the biggest topics that we will address going forward to the next high-level meeting on NCD happening in 2025. This is identified as one of the least developed. It's not that we ignore it, but I think you have spotted that the language is not as strong as we should want to see. So I think when we in 2018 got the decision from the heads of state to include air pollution, that was a very good step forward. But of course, environment is much, much broader. So I think it goes for the cancer community, but as Cary said, it's really something the whole NCD community needs to address. And we are developing this with our colleagues at WHO, with Maria Arnera's department, and we need the support from all stakeholders again to be very clear. But I want to sort of make an, let's say, a positive note, because this is why also non-communicable diseases as a concept is very important, because this is one of the few ways where we can really see the risk factors impacting directly on diseases. And I think that's the way to make people, policymakers, also people affected by, understand the need to act, like, for example, air pollution, cancer, air pollution, cardiovascular diseases, as was mentioned by Cary as well. So thank you for the question.
Looks like we've come to the end of the press conference. That's all time we have now. So thank you very much for joining us online. Those of you who are online, those of you in the room, thank you very much. For those of you who want to talk to any of the speakers one-to-one, I believe they'll be around for a while. If you also need to follow up later with any speaker, please contact Eric. And I can't see Eric's at the back, waving at the audience in the room. I don't think the online audience can see Eric, but you can contact him online or put something in the chat, or Michael Kessler from the World Cancer Congress comms team, again in the room, but again, I guess you can contact online through the chat. Thank you very much. I do hope you enjoy the World Cancer Congress, a fantastic community downstairs, buzzing with enthusiasm, and they want to make a difference in cancer control around the world. So thank you very much for being here today.